In the last video, we covered a bunch of really interesting topics regarding the way the lung and chest wall work, all the different little pressure changes that go on inside the alveoli, the intrapleural pressure. We discussed some changes with aging and how residual volume becomes bigger, but TLC remains the same. And it was nice. It was a good lecture. Right now I'm going to go over a couple extra notes from some other resources that I've put into my personal first aid. Talk about that to give you a better understanding of how all the different pressures within our massive lungs work together, what they do, how they change, how those pressures change with inspiration and expiration, and then we'll start moving on to the rest of respiratory physiology. But the biggest part of respiratory physiology is really just understanding how these pressures work. So right here in this image here, as well as along with the image on the left, we're going to be looking at those different pressures, and then you can see how the pressures are broken down depending on what layer you're looking at, right? Whether it's the lung, which is inside the visceral pleura, so the visceral pleura is touching the lung. You have your parietal pleura, which is touching your thoracic wall, and then in between those you have your pleural cavity. All right, so it's all color coded here. Number 1 says, at rest with no air movement, air pressure in lungs is equal to the atmospheric pressure, which is pretty much just considered the 0 point. Pressure in the pleural cavity is less than pressure in the lungs. This pressure difference keeps the lungs inflated, right? So pressure inside the pleural cavity is less than the pressure that's inside the lung. This allows the lung to have more pressure and keep it inflated, right? And if you ever get a physiological question about what keeps lungs inflated, is because the pressure in the pleural cavity is lesser, right? Number 2, inspiration. So now, inspiratory muscles contract and increase the volume of the thoracic and pleural cavities, right? You can see how the arrow here is showing you that the contraction is making the thoracic wall expand outwards. The volume in the pleural cavity is increasing, and the pressure in the pleural cavity is further decreasing, right? It was already lower than inside here to begin with. Pressure in the pleural cavity was already low. Now pressure in here is even getting lower because volume is increasing. And you should remember from physics the equations that relate pressure and volume to each other. They're inversely related to each other. So as volume is increasing, pressure is getting even lower in this pleural cavity. Pleural fluid in the pleural cavity holds the parietal and visceral pleura close together, causing the lungs to expand. As volume increases, pressure decreases and air flows into the lungs. Right, so what's happening in these first 2 stages? In the beginning, pleural cavity had low pressure. Then you started breathing in, and pressure went even lower. Remember when we were looking at these curves, inspiration causes the pressure to become more negative, right? And even here, the intrapleural pressure goes towards the minimum as you're breathing in. So pressure in this area, inside the pleura, gets more lower. This graph here is the same thing as the graph that's given in the book way up here. Right, but what they didn't do in this one is that they didn't show you, in the one in first aid, they didn't show you what this difference here means. Right, what this gap in between the 2 curves is supposed to tell you. They didn't show you that. So the other graph I'm showing you is the same exact thing. You have this curve on the top, you have your sine curve kind of thing here, and then you have this one down here. Same exact curve that's in the book, but it's got some other things labeled to it. So you can see that as you're breathing in, the pleural cavity gets bigger, pressure in here decreases even more, allowing the lungs to expand even more so you can keep breathing, right? So you're inspiring air. So this more negative decrease in intrapleural pressure is necessary for you to be able to breathe. Now, what happens in expiration? You can see there's the same gray arrow going back to the way it was, right? Back to the way things were. So volume in the intrapleural cavity is going to decrease, pressure in the intrapleural cavity is going to increase. Expiration. The inspiratory muscles relax, reducing thoracic volume, and the lungs recoil. Simultaneously, volumes of the pleural cavity and the lungs decrease, causing pressure to increase in the lungs, and air is now pushed out. Air flows out. Resting state is now re-established. Alright, so very important to be able to understand how the intrapleural pressure helps you breathe. When you're trying to breathe in, intrapleural pressure has to decrease more than it already was. Right, it was low to begin with. It was lower than lung pressure to begin with. It decreases even more, allowing you to bring air in The intrapleural pressure decreases even more to allow you to bring air in. And then when you're about to breathe air out, intrapleural pressure just increases again. And that's directly related to whether or not your thoracic muscles are contracting. Right? So if you have weakness in thoracic muscle function, this won't really work too well and you won't be able to breathe well. Right? So that's one thing that you want to watch out for. Now, what was the gap between the intrapulmonary pressure and the intrapleural pressure? What is this gap called? That's your transpulmonary pressure. The difference between the two curves is your transpulmonary pressure, which is basically the pressure in between the two. That's literally what transpulmonary means, right? So since it's called transpulmonary, it even denoted and looks like the pressure between the two, right? Mathematically and visually. And that is something you can get a silly question on, so just be ready to, calculate that based off of the numbers given. So let's go into it a little in more depth, right? So here, now we're looking at the alveolar pressures, right? Remember we were talking about in yesterday's video that alveolar pressure becomes more negative as you're breathing in and then comes back to normal, and then becomes more positive as you're breathing out and comes back to normal. But they reach the maximum negativeness and the maximum positive number halfway through inspiration and halfway through expiration. And we were talking about why that happens, right? Why is it that the maximum or the minimum, I guess, would be, no, this is considered the maximum negativeness or the minimum value. The most negative point is halfway through inspiration, right? Not like intrapleural pressure where the most negative point is when you're done with inspiration, right? So why is halfway through inspiration the most negative point of pulmonary pressure? And that's because the rate of air income, right? So we were talking about how quickly air is coming into the lungs and how quickly air is reaching the alveoli. When you first start breathing, right, all of this happens within a second. There's no time value on this y-axis here, but if there was, this would just be 0 to 1 second pretty much. So in between, this would be half a second, a quarter of a second, 3/4 of a second, like that. So in a quarter of a second, when you're breathing in, majority of the air that you were going to breathe in is already in. And then the other quarter of a second is just a little bit more air coming in, and then you're done breathing in, you can't breathe in anymore. So since the maximum rate of inspiration is in the beginning, right, the alveolar pressure becomes most negative halfway through. Then it starts going back to normal. And then when you're breathing out, same thing again. When you breathe out, in the first quarter of a second, majority of the air is already out of your lungs. Then the other last quarter of a second is just a little bit more air that needs to leave, and you're done, right? So here, let's take a look at one more, set of notes regarding the same stuff. Get a better visualization of it. Make sure we master this, and then we'll move on. So on the top, I wrote flow of air. What is the YouTube is not receiving enough video to maintain smooth streaming. Viewers will experience buffering. And what is causing that? Let me just close a couple browsers, I guess. This should better stay HD. Okay. Yeah, there's nothing else I can really do. It's really weird when I'm in America and internet is slow, because internet was a little slow when I was in the Caribbean islands, and it's always slow when I'm in India ever visiting. So when I come back to America and I find internet problems, I'm like, really? Like, we're supposed to have slow internet here sometimes? Okay, so let's take a look. Flow of air into and out of the lungs occurs by bulk flow along pressure gradients created in between the external environment and the alveoli. During quiet breathing, these pressure gradients are created by contraction of the diaphragm and the external intercostal muscles during inspiration, and the elastic recoil of the lungs during expiration. The alterations in pressures in the pleural space, intrapleural pressure, and the alveoli, intraalveolar pressure, right, those are all the different names of the pressures, can be studied separately and become important in studying the volume changes with the changes in pressure. Right, so you have your intrapleural pressure and you have your intraalveolar pressure. Those are the two things. So PPI and P-alv, right? Very important to understand how those guys work. We just talked a lot about intraalveolar pressure, right? Intrapleural pressure right now, right? We just discussed how the intrapleural pressure changes to allow you to breathe better. Now we'll look more about what's happening with intraalveolar pressure in number 2. Number 1 is a little more about the same stuff, intrapleural pressure. So it goes on to tell you intrapleural pressure changes during inspiration. The intrapleural pressure at the commencement of inspiration is approximately negative 2.5, right? And you can see that right here, right? So this is between negative 2 and negative 4, right? So about negative 2.5. in relation to the atmospheric pressure, which is considered to be the 0 point, at the base of a lung. This is achieved by the elastic recoil forces of the lungs acting inward and the recoil forces of the chest wall acting outwards. With the onset of inspiration, the diaphragm contracts and pulls the attached parietal pleura downwards, while contraction of the external intercostal muscle pulls the rib cage and the attached parietal pleura outwards, right? So your rib cage, when it contracts, is pulling the entire pleural cavity downwards, making that pleural cavity area bigger, and your rib cage is pulling outwards, also pulling the parietal pleura outwards with it, making that entire intrapleural cavity bigger, right? So you don't have to per se memorize the fact that intrapleural cavity gets bigger here, right? You know that when you breathe in, your chest gets bigger. Your lungs don't get bigger though, but the parietal pleura pulls outwards, giving you more space in between the parietal and visceral pleura, which is your intrapleural space. And when that space increases, of course, now that you have more space, pressure decreases. With the onset of inspiration, the diaphragm contracts, blah, blah, blah. This causes the negativity of the intrapleural pressure to increase, right? It becomes more negative. So now it'll go from negative 2.5 all the way down to negative 6, allowing you to breathe air into the lungs. When there is no airflow, so now we're looking at intraalveolar pressure during inspiration. Yeah, I'm from India. I go like every couple of years, but I don't really plan to go back anymore. Kind of tired of going back to India. Now I'm looking more forward to like traveling other countries. Last time I went back was 2 years ago, and it was a nice time, but really it's not per se worth it because all my cousins are like in different states and stuff in India, and no one's really free, and there really isn't much to do besides getting really sick. So yeah, I've been spending time making plans to travel other countries now, but of course I have some family in India that I might have to go back and see at some point, but I really won't be staying for long at all. Didn't enjoy my trips to India at all. Alright, so intraalveolar pressure during inspiration. When there is no airflow in between the environment and the alveoli, the intraalveolar pressure equals atmospheric pressure, and that's that 0 point right there. When there's no airflow, you're not breathing in, nor are you breathing out. And this occurs 3 times. It occurs before you start breathing in. It occurs when you're done breathing in, because at that point there's no airflow. Remember, we're talking about the rate of air movement. So air movement stops as soon as you're done breathing in, and then also air movement stops when you're done breathing out. Right, so this point of 0 pretty much occurs 3 times when there's no airflow at all. Not that there's no air. There is air. When you finish breathing in, there is air, but there's no air flow. So remember, alveolar pressures are related to how quickly air is actually coming in or going out, right? And when air is coming in really, really quickly, you reach this negative point. And then the rate of air coming in slows down a little, so it goes back to 0. So basically, this line is showing you how quickly air is moving, not how much air is moving, right? So if air is moving in really, really quickly, you become very negative. Then you start going back to 0 again because air movement is slowing down. When air is moving out really, really quickly, you go more positive 1. And then when the air going out slows down, you go back to 0 again, right? This is all about air flow. Very important key word here. So let me actually make that red. Where relative to atmospheric pressure. Airflow, there you go. Right, so airflow is the key word when it comes to intraalveolar pressures. Whereas with the intrapleural pressure, the main thing was muscles, right? Your diaphragm, your chest muscles, all of those guys pull the parietal pleura, right? This parietal pleura away from the lung, making the intrapleural volume bigger and reducing pressure in the intrapleural area, allowing you to breathe a little more in. So that's everything about those two guys. Then at that point, like once you're done looking at that, you should be really pro about if anyone asks you to discuss, tell me more about intraalveolar pressure, you could tell them it's related to airflow. When air is flowing into your lungs really quickly, it becomes more negative, then it goes back to 0 when you're done breathing in. When air is leaving the lungs really quickly, that's expiration, it goes to a positive 1, then goes back to 0 again when you're done breathing out. Right, that's all intraalveolar pressure is. Intrapleural pressure is all about your muscles contracting and pulling the parietal pleura away from your visceral pleura, making the intrapleural cavity bigger, reducing intrapleural pressure, allowing you to breathe more air in. That's all you have to explain. If anyone tells you to tell me more about intrapleural pressure, tell me more about intraalveolar pressure, super easy stuff now. And then, of course, when you look at it visually, you know exactly what's happening. The more you breathe in, the more you pull the muscles outwards, make your parietal pleural get stretched out further away, and make your intrapleural pressure more negative the more you breathe in. And then when you start breathing out, you bring it all closer together again, making the intrapleural pressure super high. Right? Pressure goes back to the negative 2.5 that it was at. Super simple stuff. And this image here, this one is showing you what happens that can change your intraalveolar pressure, right? And remember, intraalveolar pressure was related to airflow. So if you ever get the one that's in called normal resistance, well, it's labeled normal resistance. I wish they colored it differently. It looks like this might be a darker blue and a light blue, but I really wish they colored it completely differently. Regardless, let me just make this one red, right? So this is the increased resistance one. So the one that's blue, that's normal resistance. That's what we've been looking at, right? As you breathe in, it goes to -1, and as you breathe out, it goes to +1. Now, if you have increased resistance, right, you want to think of all the pathologies that can give you increased resistance. If you have increased resistance, then as you're breathing in, intraalveolar pressures will be bigger numbers, bigger absolute values, right? So now it goes up to -2 when you're breathing in, and it goes all the way up to +2 when you're breathing out. And that's not normal, right? So if you ever get a question where they want to give you visualizations and stuff and try to test you on that and intimidate you, don't get intimidated. If you're seeing numbers that are bigger, right, numbers that are more negative and more positive for the intraalveolar pressures, that's just showing you increased resistance. And then you look at all your answer choices and you pick whichever answer choice is any pathology that has increased resistance. Super straightforward stuff. And that's really it. That's nothing. There's nothing else to talk about. In this graph, there's only one more thing, which is volume of breath, and that you already know. That's just volume of breath, you breathing in, right? That's the only thing that's left to explain over here. So during each breath, the pressure gradients move 0.5 liters of air into and out of the lungs, right? But that's not something that's brand new information, and that's not something that really changes much per se. All right, but if it does, then you're probably missing a lung or something, right? Or you have severe lung damage. Other than that, this one up here almost never changes. It's going to be changes in here, changes to the transpulmonary pressure, because if any one of those lines change, transpulmonary pressure changes. And that's just a basic summary of all of your lung physiology, right? So I really wanted to start off this video with that summary because that's all the stuff we've talked about so far. We're done discussing lung physiology. The rest of the stuff is other physiological things that affect the lung. And one of the bigger things we're going to be looking at later on is your oxygen hemoglobin dissociation curve. This is the last thing that's related to lung physiology. It's not necessarily lung physiology itself though, right? This is more hematology related topics. So it's a mixture of the two. And as far as pure lung physiology was concerned, we're done with that. So now on the next page, the next topic is cyanide versus carbon monoxide poisoning. So cyanide versus carbon monoxide poisoning questions are usually really simple. The difference between the two things is really vast. There's almost no overlap. So it shouldn't be difficult, but they can try to come up with things that, might try to make the question a little harder. But it's almost always very evident and super easy to pick. The reason both of these guys are even a type of poisoning is because both inhibit aerobic metabolism via the inhibition of complex 4, which is part of your electron transport chain. So we saw this way in the beginning when we were doing biochemistry, where we were looking at the electron transport chain. Remember, complex 4 was the one that was labeled COCN, 4 letters, right? 4 letters for COCN, because those guys inhibit complex 4. So let's just take a quick look at that. Let me see, electron transport, where does it pop up? Or does it even pop up? Yeah, here we go. Okay. So this page is the one where we first saw it in biochemistry, right? When we did our biochemistry videos, we talked about things that inhibit each of these complexes. Complex 1 was inhibited by rotin 1, right? You can remember known as rotin 1. Antimycin is N3-mycin. This is the guy that inhibits complex 3. CN and CO, right? Cyanide and carbon monoxide, that's 4 letters, right? And they kind of changed it up in First Aid 2019. They changed it up. It used to be like this in First Aid 2018. CNCO, 4 letters, so it inhibits complex 4. But they changed it up because the ides, like azides also inhibit the complex 4. So this was, in terms, a better new mnemonic. So cyanide, monoxide, and other ides. So IDES is the new 4 letters they work with now. All these ides inhibit complex 4. So these guys, just a little tiny revision. You have to make sure you know it. Don't forget this shit. It can be really annoying information, but you get questions on it. You definitely get questions on it. So you can't really per se forget it. And of course, 2,4-dinitrophenol and aspirin overdose. Remember, aspirin overdose is a really high yield topic when it comes to acid-base physiology, because early aspirin overdose and late aspirin overdose are kind of different effects, and you can have overlapping acidosis and alkalosis symptoms. So really important to remember how that works too, and it is related to how you're gonna mess up your mitochondria, basically how you're gonna mess up the electron transport chain. So that's what we were looking at over here. So CN and CO, right, they inhibit complex 4, leading to hypoxia that is unresponsive to supplemental oxygen and increased anaerobic metabolism, right? So you're going to have a patient who is hypoxic, and if you give them more oxygen, it's not really going to help, because the problem isn't that they don't have oxygen. They have oxygen. Is their electron transport chain that's not working? And since their ETC is not working, they're going to be doing more anaerobic metabolism, which is not enough to sustain human life, all right? Both of these can lead to pink or cherry red skin, usually postmortem findings, so by that point they're already dead. And both of these, cyanide and carbon monoxide poisoning, both of these can lead to seizures and coma. And in America, and in general probably all over the world, more common is the carbon monoxide poisoning, right? This one is very common. It's a mistake. It happens, because people can't really smell it, right? So let's look at that first, because it is the bigger deal. So carbon monoxide is odorless gas. Odorless gas. That means that if you're anywhere and you smell a weird kind of gas, at least you can rest assured you didn't just inhale carbon monoxide and you're not going to die immediately, right? So if you smell the gas, that's actually good. Thank God you can smell it. If you don't smell it, you won't even know that there's gas around you. You're breathing it in, and carbon monoxide has much more affinity than oxygen. Like, it can just grasp our hemoglobin really, really tightly, and oxygen cannot per se displace it. So how do you find carbon monoxide? Well, you can have it from anywhere that there's prolonged fires. If your car is just on, this is a common scenario. A lot of times during the winter, right, especially in states in America where winter is common, what people will do is they'll turn on their car before getting in the car. Right, so like a lot of cars have remote ignition. So like I can just click a button on my car key thing, and the car turns on, right? And my car might be sitting in the garage, right? It's a closed garage. And why would I turn it on beforehand? It's because that allows the car to heat up, so that when I get in the car, as soon as I turn on the heat, it'll be hot. But there's a problem with doing that. Now, if I leave the car on for too long and then I go into my garage, that car exhaust might actually be releasing a lot of carbon monoxide that I won't smell, that I won't know this is happening, and then I'll breathe it all in, and within minutes I'm just going to pass out and then possibly even die. Gas heaters can also do this, although it's not that common to find gas heaters anymore. It's very rare to hear about a gas heater doing something like that, but of course in more impoverished areas, it is possible someone might have a gas heater, right? So, and of course, fires are also more common in poorer districts that don't really have everything up to date. So those are things you want to watch out for in your question stem. Someone does something like that, you know there's going to be carbon monoxide around. How do you treat it? You have to give them hyperbaric 100% oxygen, right? You're going to give so much oxygen that you're hoping it'll sort of displace the carbon monoxide, but it does not work too well. It does not work too well. But unfortunately, that's really all you can do. Signs and symptoms of someone who had just had carbon monoxide poisoning. What does it look like? Well, first things first, they're going to have headaches and dizziness. That's going to be the initial thing they'll complain about. Multiple individuals may be involved because the whole family, right? So look, they put family with similar symptoms in winter. Why? Because the scenario I just described, right? Me and my whole family, we all might be about to go out, so I turned on my car heater, turned on my car to leave it on and get hot. By the time we all get in the car, we're all inhaling carbon monoxide, right? And that's the problem there. So multiple individuals may be involved in this kind of scenario, classically associated with bilateral globus pallidus lesions on MRI like that, which I've never seen in a question, all right? I've never seen that in a carbon monoxide question, but if they do give it to you in a question, then this is what you're looking for, right? Globus pallidus lesions on MRI, although rarely, you can also see this with cyanide toxicity as well, right? So it's not exactly diagnostic per se. Now, the patient will have a normal pulse oximetry, oxygen saturation. Why? Because it cannot tell the difference. The pulse oximeter device, it cannot tell the difference between oxyhemoglobin and carboxyhemoglobin. Right? So that device simply checks, is your hemoglobin saturated? And it is. It's just that it's saturated with carboxyhemoglobin, right? It's carbon monoxide. Also, although oxygen carrying capacity and oxygen content of the blood decrease, oxygen dissolved in the plasma, known as PaO2, is normal, right? So these are two things you want to watch out for in a question, right? Very important little notes. These can be answer choices. What would you expect in a patient with carbon monoxide poisoning? You would expect a normal pulse oximetry and normal PaO2. A lot of people don't think these things are supposed to be normal in these patients because they have carbon monoxide poisoning. But carbon monoxide poisoning doesn't mean anything else besides the fact that the carbon monoxide has removed oxygen from the hemoglobin and taken its place. That's all it's done. But you still have oxygen in you. It's all in you. That's why giving oxygen naturally won't really fix the issue, but hyperbaric oxygen can. Effects on the oxygen hemoglobin dissociation curve. Well, when you have increased oxygen binding capacity, right, because you have a lot of carbon monoxide, but the oxygen isn't being used, and you're going to have decreased oxygen unloading in tissues, right? So more oxygen binding capacity with left shift in the curve and decreased oxygen unloading in tissues. Why is there decreased oxygen unloading? The reason there's decreased oxygen unloading is because you don't even have oxygen on the hemoglobin. You can't unload something you're not carrying. The hemoglobin is carrying carbon monoxide. Not going to work. But there is more oxygen binding capacity, much more oxygen binding capacity, because it's not binding any oxygen right now at all. Unfortunately, the capacity alone is not good enough because carbon monoxide is not going to let that happen. Carbon monoxide binds competitively to hemoglobin with 200 times greater affinity than oxygen, right? And that's really problematic. So now here in this graph, you could see, right, this black line, the first one, is normal, right? That's the normal cooperative binding that you note. So that's why it has this S shape, because of the cooperative binding. And that's your 100% hemoglobin, right, with oxygen. Now, the blue one is not S-shaped anymore, right? So this one you can see is tapering off at a maximum around 9. And this is your 50% carbon monoxide carboxyhemoglobin, right? And then this other one that still maintains the S shape, this is just showing you anemia, 50% hemoglobin. So why are they showing you all this? This is because in a question, you might have to compare whether someone just has anemia or they have carboxyhemoglobin. So depending on how the curve looks, you need to be able to differentiate. If the curve gives you this kind of shape, right, that is the blue line they made, that's carboxyhemoglobin, right? Whereas if you're just anemic, then look, the normal was supposed to be like that. If you're just anemic, it just won't go as high, but it still maintains that S shape, right? So this one here, this is anemia, right? And this one up here, this is normal. And you can already see that the carboxyhemoglobin curve looks very different compared to both. It doesn't make an S shape at all. All right? So very important to be able to catch that kind of difference, because you can get questions where they give you that shit and you just have to find that from the question itself, and it's really annoying. Now, how does all of this differ from cyanide poisoning? Cyanide is a byproduct of synthetic product combustion, and it can also be ingested in the form of amygdalin, which is cyanogenic glucoside found in apricot seeds. Right, so this is why I put an apricot here. If someone ingested apricot seeds, which is a very rare thing, I really don't know why you would ingest this seed. If you've ever eaten an apricot, and you probably have, you know those seeds are huge and they don't really per se have a taste, and they're rock hard. You can't really bite into it. So if you ingested an apricot seed, you're just an idiot. And at that point, you just had a bunch of cyanide enter your body in the form of amygdalin, which is problematic, right? And then, of course, combustion products, synthetic product combustion, this is a very rare thing. Almost no one does. But you can have kids messing around with something and burning it up just for fun, and that might be releasing cyanide. So that's another scenario you can possibly have, right? Sodium nitroprusside from cardiovascular pharmacology is also high in cyanide, and that's another one you have to remember, right? There was a medication in cardiovascular pharmacology. It was called sodium nitroprusside. If you don't remember, let's go back and take a quick look. Sodium nitroprusside is full of cyanide just because of the way it's built, right? That's how the medication kind of looks like. So let's see right here. I even have the image for you, right? So you can see nitroprusside, right? For hypertensive emergency, it's a short-acting medication that increases cyclic GMP to cause vasodilation by direct release of NO. But it can cause cyanide toxicity. Why? Because this is what it looks like. Look at how many cyanides it has. It has 1, 2, 3, 4, 5. And this one is not a cyanide. That's NO. Right? So 5 cyanides bound to an iron that's bound to 1 NO. Just to get that 1 NO into the patient, we're going to be giving them 5 cyanides. And this medication can definitely easily lead to cyanide poisoning, which would really suck. Alright? So you want to make sure you remember that if a patient is going to be taking sodium nitroprusside and then they all of a sudden present with these symptoms, that you know this is related to cyanide poisoning. Torgo is asking to explain cooperative binding. I don't think there was a lecture on cooperative binding yet, but basically what cooperative binding means is that as hemoglobin binds 1, 2, 3, right, it binds 4 oxygens. As it binds more oxygens, the ability to pick up oxygen becomes better, and that's because of the tertiary, the quaternary actually, because of the quaternary structure of hemoglobin. When it binds 1 oxygen, it opens up more seats for other oxygens to come, and that's why it's called cooperative binding. So binding 1, so what's happening with binding more and more? Remember I told you guys yesterday in terms of derivatives that if you ever see a line made like this, right, this is called a derivative. This line is the derivative of this black curve at that point right there. What does the derivative tell you? It tells you the rate, right? It's the slope. So you can see how in the beginning, right, this is how quickly it bound the first one, right? Then you can see up here, right, the slope gets different, and then in the end the slope goes back to being 0 basically, right? So you can see how because of binding oxygen, the rate of binding more oxygens is increasing. That's basically what's happening. As soon as it bound 1 oxygen, look at how steep this is, right? It's super ready to bind more. At this point up here, it's even more steep, and then by the time it's done binding 3 oxygens, it becomes less steep. It starts going back to 0 again. Right? So that's basically what's happening there. So the more oxygen is binding, the more quickly it's increasing. Right? It's not just like this. It's not a straight line. A straight line would be a 1-to-1 interaction where you picked up 1 oxygen, then you picked up a second oxygen, a third oxygen, and then you picked up your 4th oxygen. That's not what's happening though. You could see that as soon as it picks up its first oxygen, the rate increases super high upwards, right? And that's what we're looking out for. So as soon as it picks up 1 oxygen, it starts going up more quickly, picks up the second and third, and then it tapers off. Right, so maybe this is where it picked up a second oxygen. This is the third one, by which point it's pretty satisfied, and then it picks up a 4th one just because it can. Right? Not all of your hemoglobin is flowing around in your body with 4 oxygens. Most of them are probably carrying 3, but depending on how healthy you are, they're all probably carrying 4. Right? So that's basically what cooperative binding is. Because of the structure of hemoglobin, when it picks up 1 oxygen, it wants to pick up more oxygens after that. It's a very important thing to understand. You can get a bunch of silly questions and stuff like that. So definitely make sure you know Cooperative binding is also something only normal hemoglobin exhibits. Myoglobin, when we look at myoglobin, for example, right, myoglobin is a little different. So, and even fetal hemoglobin, right? You can see how fetal hemoglobin also does cooperative binding, but it has much more affinity, so it's doing the same exact thing, but even more quickly, right? That's basically all you're seeing with that. And then where did they talk? Oh, and myoglobin. See, myoglobin is different. It doesn't have an S shape to it. Right? It doesn't really have an S shape to it. It again has the same, this kind of thing going on, right? It doesn't really do the S. It doesn't do the S thing at all. So myoglobin is a little different, but fetal hemoglobin and normal hemoglobin both exhibit cooperative binding very, very ideally. But you can see that here they tell you myoglobin is monomeric and thus does not show positive cooperativity. Right? The curve lacks a sigmoidal appearance. So this positive cooperativity discussion will come up more when we get to the oxygen hemoglobin dissociation curve. But coming back to cyanide, oh, I put this here too, sodium nitroprusside. There you go, right? So sodium nitroprusside is one of the medications you might give a patient because of hypertensive emergency, and they might have cyanide poisoning because of all the cyanide that's in the structure of nitroprusside. And then if you ingested this apricot seed, that can also cause cyanide poisoning. So how do you treat it? Hydroxycobalamin, right, which ends up making cyanocobalamin, or induced methemoglobinemia with nitrates and then sodium thiosulfate. Now, test writers like writing questions on both of these things. They write questions on carbon monoxide because it's very common, right? It's a very real thing and everyone should know about it. They like writing questions on cyanide because the treatment is a little complicated, right? So how does this other treatment work, right? You induce methemoglobinemia with nitrites and then treat the methemoglobinemia with sodium thiosulfate. That's probably the better way to go, and it's a really interesting thing. So what you're seeing in this image down here is basically that, right? If you give someone nitrites, right, the nitrites will displace the cyanide and put the nitrite itself inside, right? So you can actually now excrete cyanide very easily. You no longer have cyanide poisoning in your electron transport chain, but now you have methemoglobinemia because you have all that excess nitrite. The methemoglobinemia can then easily be treated by giving someone thiosulfate. Right? Thiosulfate is used to bind the cyanide methemoglobinemia complex, forming thiocyanate, which is excreted renally. Right? Very interesting thing. We're going to see methemoglobinemia on the next page. That's the last kind of hemoglobinemia you need to know about. But this is probably the better way to go with, right? If you give someone hydroxycobalamin, that's also a fair answer choice. This also makes cyanocobalamin, and then that also deals with the issue at hand. How do you know someone has cyanide poisoning? Well, they're not going to present with any of these symptoms, that's for sure, right? And then on top of that, they're most likely going to have cardiovascular collapse, which really sucks, right? This is something that can kill someone, especially if they're really old or if they don't have a good heart to begin with, they're not that healthy, etc., etc. Very important to make sure that you note that, right? So this is probably going to be something that's in the question. They most likely will not mention that the breath has a bitter almond odor. That's pretty rare. Like it's not that that's rare, but it's rare that they'll mention it in a question, right? So that's probably not going to be given, but the cardiovascular collapse most likely has to be given because there really isn't much else to this. There aren't that many other symptoms they can really talk about. And as far as the effect on the oxygen hemoglobin dissociation curve, the curve looks normal. It doesn't really affect hemoglobin. Cyanide doesn't do much to hemoglobin at all. Carbon monoxide does. All right. Oxygen saturation may appear normal initially, but oxygen saturation will become worse later on, right, depending on how long it's been since the cyanide poisoning had occurred. Now, at the bottom here, this is just a question about clubbing. We'll come back to that, but I want to talk about methemoglobinemia before we're looking at other stuff. So methemoglobin is the oxidized form of hemoglobin. So let's actually take a look at it. First, you have to know what the difference is between oxidized versus non-oxidized, right? And remember ferric versus ferrous. So the oxidized form of hemoglobin, which is ferric, Fe3+, does not bind oxygen as readily as the ferrous form, but has high affinity for cyanide. Right? So the oxidized hemoglobin has high affinity for cyanide. Ferrous is the one that binds O2. And you can remember that using the mnemonic they've put here, the color coding, right? Fe2+ binds O2. Very easy to remember that. But Fe3+ doesn't necessarily bind oxygen. However, Fe3+ really likes CN. It likes cyanide. Iron in the hemoglobin is normally in a reduced state, right? Which is ferrous, Fe2 plus. Reduced means a smaller number, right? More electrons. More electrons gives you a less positive number. Leads to tissue hypoxia from decreased oxygen saturation and decreased oxygen content. Methemoglobinemia may present with cyanosis and chocolate-colored blood. And this is something that's often given in the question. Chocolate-colored blood, right? Really dark blood. Nitrites from dietary intake or polluted intake, high-altitude water sources, etc., and benzocaine can cause poisoning by oxidizing Fe2 plus into Fe3 plus. Right? Anything that oxidizes the iron in your hemoglobin will lead to methemoglobinemia. So if you get like a bullshit question where they're making something up and they don't mention nitrites or benzocaine or any of that, but they tell you that the patient did something where the iron in their hemoglobin became more oxidized, you know they're talking about methemoglobinemia. Methemoglobinemia is basically the concept that the iron in your hemoglobin became Fe3 plus. And if the iron in your hemoglobin stays Fe3 plus, you will not be able to bind any more oxygen, and that's going to suck, right? But remember, this is the same thing you can use to treat cyanide poisoning, right? Because if you induce methemoglobinemia by giving somebody a bunch of nitrites, you will now have methemoglobin bind all the cyanide up, and then you can treat the methemoglobinemia with many things: methylene blue, vitamin C, and then the other thing that I wrote up here, sodium thiosulfate. All of those are different treatments for methemoglobinemia, right? So in the book they teach you methylene blue and vitamin C, but they don't write about sodium thiosulfate here. I'm not sure why, but it is a thing you use to treat this. So they mention it here too, sodium thiosulfate. Right? Now I get that the sodium thiosulfate was mainly to treat the cyano form, thiocyanate. So maybe that's why you don't necessarily need it. If you don't have cyanide involvement, then you would just pick methylene blue or vitamin C as an answer choice. Right? But if you're working with the cyanide aspect of things, then you have to use sodium thiosulfate. Methylene blue or vitamin C would probably not be enough for that stuff. I wrote here how they work too. So methylene blue reductase reduces the Fe3 plus back to Fe2 plus again, which is basically the treatment for methemoglobinemia. Methemoglobinemia is secondary to oxidizing medications such as nitrites, dapsone, benzocaine. Right? Dapsone will be given to a patient on multi-drug therapy for leprosy. It can also be part of many other medications, but just keep in mind anyone with leprosy would probably be taking dapsone, and that might be a patient who might present with methemoglobinemia. Most questions don't directly tell you, oh, you have a patient with methemoglobinemia. You have to figure it out, and oftentimes you just have to deduce it based off of presentation and history, right? You have to be able to guess like a genius or something. Methemoglobinemia can also be inherited in an autosomal recessive manner where the enzyme cytochrome B5 reductase is just deficient. So that's something else you want to watch out for, right? So that's what I'm telling you. Don't really worry about what causes methemoglobinemia. Just keep in mind if all the iron in your patient is Fe3 plus, that is methemoglobinemia, and you need to fix that by giving methylene blue or vitamin C. Right? And as far as cyanide poisoning is concerned, it's not that special, but the treatment is special. It's because it's like a cool secondary kind of treatment. To treat this problem, you induce another problem and then solve that problem because that one's easier to solve. So to treat cyanide poisoning, you give them nitrites, make them make thiocyanate, and then give them sodium thiosulfate to excrete it all. Right? And that's really it. So that's your entire cyanide, carbon monoxide, and methemoglobinemia issue. To wrap it up for today, let's just take a look at this question, and then in the next video, we'll go into oxygen hemoglobin dissociation curves. So here we see from UWorld, a 65-year-old man who recently moved to a new community comes to the physician for a routine health maintenance exam. He has multiple medical problems. He has a 20-pack year smoking history and consumed 2 to 3 ounces of beer daily for the past 20 years. So pretty much he's also an alcoholic. Exam of his joints show clubbing. What disease is most likely to cause the clubbing? And this question was literally here just to teach you what clubbing is. So the concept was anything that caused you to be hypoxic would cause clubbing. And they put a bunch of answer choices there. But the correct answer for those choices was bronchiectasis. Other answer choices were not related to the lung. Digital clubbing shows fingers with a drumstick appearance, flattening of the rail folds, and shininess of the nail. Clubbing is associated with a number of chronic diseases that cause hypoxia. So then they had these three things that could be possible answer choices. So number one, lung diseases like lung cancer, tuberculosis, cystic fibrosis, bronchiectasis, pulmonary hypertension, empyema, and many other chronic lung diseases associated with hypoxia. Heart diseases can cause clubbing also, like cyanotic congenital heart diseases and bacterial endocarditis. And then other things were inflammatory bowel diseases like Crohn's and ulcerative colitis, hyperthyroidism, and malabsorption. All of those are also things that can cause clubbing. The pathophysiology is not completely understood, so you won't really necessarily get a question on it. Hypoxia increases peripheral megakaryocytes and platelets which clump and impact in the fingers and toes. There, PDGF is released and VEGF promotes vascularity, leading to this. Right? And this is discussed, the clubbing stuff is discussed at the Shamrot sign. Right? The Shamrot sign. So you can see how at the distal phalangeal joint, you have too much, the width increased. And that's a really weird thing that occurs in people who have hypoxia. Alright, so thank you very much for joining. Next video, we'll continue on and talk about the oxygen hemoglobin dissociation curve.